First, we're going to talk about track ER. And this study has two components that we'll talk about in just a moment. But Niam Cunningham, who works with Nick Turner, gave two very nice presentations at ESMO Breast. And this was the first main presentation looking at the rate of ctDNA detection during surveillance in track ER. And this is going to be a component of all trials that are looking at intervention for patients who have MRD to see whether or not we can change ultimate outcome. And of course, just so you can see, Fabrice is the second to last author here as well, because this is a trial between the UK and France. So the incidence of ctDNA positivity in high-risk HR positive, HER2 negative early stage breast cancer is of great interest. And actually, in the US, many patients are having these ctDNA tests, and patients are looking for ctDNA to decide if they should do treatment or not, which of course we have no data about. But I think the main area of interest for oncology is if we change therapy in patients who have detection of ctDNA, can we change outcome? So track ER, the second component of track ER is to switch in patients who have detected ctDNA and do not have evidence of progression on staging. That data is, of course, not mature. And you can see that's the randomization part where patients will go to palbo fulvestrant or standard endocrine therapy, which is listed there. So to get on the study, in order to screen for ctDNA, patients have a personalized or so-called tumor-informed ctDNA assay. So it uses a plasma detect ID MRD, with whole exome sequencing that tracks up to 50 personalized variants. And patients who are eligible had high-risk disease, and there is already studies that have shown that detection of ctDNA over time in patients who have lower risk HR positive disease, you get very small numbers. So they included patients with 4 or more positive lymph nodes, tumor of greater than 5 centimeters, 1 to 3 positive nodes, plus high-risk features, standard high-risk features, bigger tumor size, grade 3, high genomic risk score. Also patients who had residual positive nodes or a greater than 3 centimeter tumor after neoadjuvant chemo were eligible. And then they did blood draws every 3 months. 901 patients started the surveillance with a failure rate of 16% due to insufficient tumor or variants, which is interesting, and we'll talk about that a little bit in the discussion. So they found ctDNA in 11.6% of patients, so not a small number given the number of patients we see with HR positive, HER2 negative disease, and many of which have high risk features. Per test, the rate was about 1.9%, so 107 out of 5,700 samples. So you have to do a lot of testing to find this. And in the first test, interestingly, similar to what was seen in SERENA-6 in the metastatic setting, there was a higher rate of positivity because, of course, these patients weren't being checked beforehand. They just entered in. So 5% first test and 1.3% subsequent. And 59% of positive tests were after an initial negative test. So what happened in those patients? And you can see in that bar graph, the detection rates per visit month, and that the rate of positivity is much higher right up front in that little green bar versus as you go farther out. And in fact, in PADA-1 in the metastatic setting and now in SERENA-6, there seems to be people whose cancers get ESR1 mutations and those who don't, which makes perfect sense. But I guess we didn't really understand that. And there is a time course where you get the mutations, and then after that, you just don't ever get them. So at the time of the first positive test, 44% of patients had evidence of metastatic disease on staging, not unexpected because they hadn't been having regular scans. If the ctDNA was positive at baseline, more patients had evidence of metastatic disease versus being detected later, which also makes sense. Patients who had more disease burden had higher rates of ctDNA being positive, more nodes, higher grade disease. So basically their conclusion was that it's feasible to test true molecular relapse without evidence of metastatic disease on scans is not uncommon, but there are questions that remain about optimal testing, sensitivity, the failure rate, and whether or not, of course, the key issue is, does early intervention change the outcome? And here you can see the median allele fraction, which goes down in later months of testing, which goes along with the fact that less people had metastatic disease. And some of the questions that we could discuss in our panel discussion are, ctDNA detection, tumor-informed assays versus tissue-free assays. We all get frustrated when we send off our tumor-informed assay and we can't get a test back because there isn't enough tumor. But there are issues in terms of sensitivity and what you're looking for. And we can talk about this more about what the future holds, about whether or not we should be looking in one direction or the other, or both of these approaches have value. In the MRD setting, this is a slide from Peter Dybski, who was the discussant of this, basically said if you were adding therapy, you could use a tissue-free test, but if you were de-escalating and withholding therapy, you would want a tumor-informed assay. We'll hear what people think about that as well in our discussion. And then there are numbers of trials looking at interventions for ctDNA positivity without evidence of disease on scans. The sensitivity of our scans being a question, of course. And this slide was part of Erica Mayer's discussion also at ESMO Breast, showing all these different trials that exist, TRACK ER in the late adjuvant setting, the DARE trial, and numerous other trials, including SURVIVE, LEADER, ER, et cetera, and then risk stratification at baseline that might help us as well, although these trials tend to be smaller.